Well, if you weren't awake before, you are now.
It's very exciting music, Paula.
It is very exciting music. Isn't it amazing? But it wasn't ear-blowing like it was last time. Welcome, everybody who that I'm lucky enough to have come on board with Facebook and StreamYard. What will be happening here for the next 45 to 60 minutes is that we'll be talking all things pathology, answering loads and loads of your questions, and I'm delighted to have amazing Ruth Werner on board with me. How are you, Ruth?
I'm very well, Paula. It's so nice to be here with you. It's just an amazing thing that we can do this, isn't it?
It is absolutely incredible. Guys, I'm going to give you a little bit of feedback, a little bit of info about me. Most of you know me, and lots more about Ruth. My name's Paula Nutting. I'm a musculoskeletal therapist. I have my degree in health science in musculoskeletal therapy, and I've been running courses nationally and internationally and have a private clinic, which you can see behind me. And part of my journey is to get as much information out to you therapists that will help you engage in your clients and patients, to feel connected with your community and feel connected with the people that your peers around you, which is why I'm trying to get these events happening in a semi-regular basis with amazing people. Today, I'm proud to announce that we've got Ruth Werner. She's board certified for therapeutic massage, and she's an educator, she's a writer, she's a retired massage therapist. I'm going to ask if she really is fully retired or she still does a little bits and pieces here and there. I'm just turning off that because it's dinging at me. She's passionate interest with massage therapy research and the role of bodywork for people who live with health challenges. In fact, I saw Ruth the first time in Seattle at a research foundation, which was pretty incredible. And I've also gone through what I studied at university, her groundbreaking textbook, A Massage Therapist's Guide. There it is right there, to Pathology. And that was first published in 1998 and is now in its 7th edition, and it's published by Books of Discovery. Thanks very much, Drew Beale.
Yes.
A great shout out to him. He's an amazing person. So much information and beautifully hands it out, so accessible to the general public for us. Columnist for Massage and Bodywork magazine and Massage New Zealand. Oh, I'll have to ask about that too. Yep. Serves on several national and international volunteer committees and teaches continuing education workshops in research and pathology all over the world. Ruth was honoured with the AMTA Council of Schools Teacher of the Year Award for 2005, and she was proud to serve on the Massage Therapy Foundation as trustee from 2007 to 2017 and president of the foundation from 2010 to 2014. No mean feat. Approved provider with the National Certifying Board of Therapeutic Massage and Bodywork, and board certified in therapeutic massage and bodywork. And thank you for coming on board and spending some time with me, Ruth.
What a boring bio, but thank you, Paula. I'm very happy to be here.
It's extensive and incredible. So, and your wealth of knowledge has been garnished from years and years and years of just groundwork, hasn't it, really?
Yeah, it really has. What happened was, pardon me, I live with a little chronic cough. It is not COVID. I just live with a little chronic cough.
Guys, it's Paula Nutting, your musculoskeletal specialist, and this is that awkward, cheesy kind of part of the video where I ask you a big favor. So if you want great content and lots of information, you can see down here in the little testimonials, there's free manual therapy information. There's really cool stuff on necks, shoulders, backs, hips, wrists, arms, etc., etc. I've got amazing Ask Me Anything podcasts and vodcasts that you can get free access to. If you want to get that great content, can I please ask you 3 things? 1, can you please subscribe to my channel? 2, can you hit the like button? And as they say, just smash the heck out of that like button. The more information that YouTube gets to me, the more I can give content to you. And if you can click on the bell, that will also give you timelines for when I'm actually dropping something into YouTube so that you can access it really quickly. So subscribe, like, and click on the bell. And I'm hoping to get you as much great content as I possibly can. Paula Nutting, your musculoskeletal specialist.
When I was in massage school, which was in the early 80s, we got very little information about what at that time we called contraindications. And I felt really unprepared. And among some of my early experiences of being, working in the field was having people who were asking for massage who had health challenges that I didn't feel I could work with safely until I got more information. So I was teaching at the school where I had been a student, and was encouraged to sort of make that a point of focus for me. Ultimately, when I had to leave the school because we had a move, my boss gave me a little computer and he said, we keep saying we don't get enough information about contraindications. So here, you're going to be an at-home mom now. Why don't you write us write us a handout?
Wow.
And this was before internet. There was such a time before most people had these devices in their homes. And so, the thing that I created for that school became ultimately my author's proposal saying, here, I have a vision for a project like this. It got picked up and was so much more successful than anyone had anticipated. Massage therapists were starving for someone to lay out some of the decision points about working with clients who were not completely healthy. And now I'm, as you said, 7 editions later, and in none of that time did I ever go to medical school. I didn't go to nursing school. I didn't go to physiotherapy school. I am a massage therapist who was willing to do, and continues to be willing to do, the sometimes tedious work of going through, pretty technical information in order to pull from it what are the tidbits that are going to be most important for massage therapists to know so that they can make decisions. It's really important that I don't proscribe and say, this is okay, this is not okay. It's really much more like, well, the way I described it, it's risks and benefits, right? What's the best thing that could happen for you and your client who has diabetes if you're skilled and you ask the right kinds of questions? And what's the worst thing that could happen if you are not paying attention and you're undereducated and you make mistakes? How can we create a session to get you the best benefits with none of the risks? And that's going to be up to you. And what you do with that question, Paula, is going to look really, really different from what anyone else will do.
Yeah. And I mean, I suppose it's something as simple as talking about diabetes is if you're aware that they've got diabetes, do you work firmly on the distal ends of the body, the extremities, or do you work a little bit lighter, mindful of what's happening with perfusion and oxygenation and tissue regeneration?
Right. So what's a simple way you can answer that question?
Yeah, we'll ask them.
You can ask them. Right. Knowing that this is sometimes a risk. So talk to me about your diabetes. How well are you managing it? Do you have symptoms or side effects that might affect your sensation?
Yeah. And so you got the information. So you said you didn't go to medical school, you didn't go to nursing. So you just avorously read books and got the information. And developed a handful of my favorite go-to resources that are my starting places when I'm learning something new. And then I've become very information literate in the sense of recognizing some of the signals that what I'm looking at is pretty reliable versus maybe not so much. Dr. Google.
And in this past year, haven't we learned how important it is to get a little picky about where we accept information from? Yeah,
that's so true. And most therapists probably only think with the musculoskeletal head. They don't actually think with the visceral head or pathology head as much.
It's
How do
funny
you
that
enlighten them?
Yeah, well, I mean, it's funny that you started with that. We started with diabetes. You and I were actually talking about that before we went live today. But that's a great example of why massage therapists need to learn about pathology, right? Because diabetes, I bet in Australia it's not that different from how it is here. It is extremely common. I think it's our number 6 or number 7 cause of death.
Wow.
You know, the main reason people are on waiting list for kidney transplants. A major contributor to heart disease. You know, it has all these complications. It also affects the skin. All of these systems can be influenced by body work. And so when people say, why do massage therapists need to learn pathology? My one word answer is diabetes. And it's, it's especially useful when we're talking to other medical professionals. I have a friend who's a gynecologist, and I was describing what I do, and he said, why do massage therapists need to learn pathology? And I said, diabetes. And he thought about that for a minute and went, oh,
yeah.
Oh yeah. So, and the other drum that I'm constantly beating is that even if you're working in a setting that is not strongly clinical, let's say you're working in a spa or a resort or some kind of recreational setting, and so most of what you're doing is relaxation massage, which is a blessed calling, but you're not working with people who are specifically coming to you to have you help them with their diabetes or their chronic pain or their whatever. I'm sorry, I just saw a comment from my friend. I was in a meeting earlier today with Liz. Hi, Liz. But people with diabetes go to the spa. People with cancer go on vacation. People with complex, difficult, challenging situations will sometimes go to recreational settings and want a massage. And so it's not enough to say, well, I only do relaxation massage. I don't really need to learn pathology, because your clients don't know the difference. So
that's right. That's so true. They don't even, and nor really, there's never been a focus for them to know what the difference between a remedial massage and a day spa massage and a therapeutic massage and oncology. Well, you probably should get some idea if they're manual lymphatic drainage or oncology massage, but the layperson really doesn't. And most times they there's no indicator for them to even try to learn that right. information.
It doesn't seem important. And in the United States, in the United States, it's a little different because we are a litigious society. And so and I sometimes serve as an expert witness in these suits, these lawsuits where a massage therapist has been accused of actually causing damage.
Yeah.
And it becomes the burden of the massage therapist to demonstrate that they were working within, they were applying an appropriate standard of care. If they can demonstrate that they took all reasonable efforts to be safe, then they're going to be fine. But part of those reasonable efforts to be safe is to be educated about pathology.
Yeah.
In Australia, that's not such an issue, I think. And
not as much, no.
It's maybe it's not a legal issue, but it's certainly a moral one.
Yeah. So in college, because we've got our health training package, it means that all the way through anywhere in Australia, if you go to a education facility, they're all governed by the same educational guidelines, which means that it doesn't matter whether you have gone from North Carolina to Kentucky or to wherever. You don't have to go, okay, now it's a 200 hours versus a 2,000 hours versus it's not like that at all. You can go from Hobart to Darwin and still treat. And in the health training package, I know we're so lucky that we're compliant. But it means they start with their history taking soap notes and questions right from the very start of the first clinic, they're learning how to ask what kind of basic pathologies. That's the same over there, I'm guessing.
Oh, yeah.
That's where we really have to start.
On a basic intake form.
Yeah.
Especially one that a client would fill in the first time you see them. You should have a lot of that kind of information available, not just, pardon me, not just about pathologies, but also, of course, about medications and medication side effects.
Yeah. Well, we're probably a bit light on with the medication side effects because there's so many new medications out there.
And always will be.
Mm.
Yeah, and always will be. I'm actually working on creating an online self-paced continuing education course called An Introduction to Pharmacology. That will, at least lay some scaffolding that people can use for making decisions.
One of us froze for a second. What's the name of the program?
Oh, it'll be called A Massage Therapist's Introduction to Pharmacology.
That's frozen. Massage therapy pathology.
A massage therapist introduction to pharmacology.
Pharmacology, great, thanks. I was like, going, both times we've frozen. I'm just going to do a shout out, guys, that if this is going to be, it's a Q&A thing. It's like we're focusing, calling it a Stump the Pathology Teacher. So people like Liz or anyone else that's out there, if you've got a question that you want to ask Ruth, please
plug it in.
Type it in the chat box so we can have a bit of a conversation over that. One of the girls, Tanya, and I don't know if she's on board or not, but she asked earlier about any autoimmune. That apparently down south they're actually seeing more younger people in their 30s coming down with autoimmune, and I don't know whether she's talking about Lyme's disease or anything particular because she didn't actually expand on it. But are you seeing anything over in America that's suggesting that there's younger people with autoimmune issues?
So that's a huge question, and we can easily spend the rest of our hour on that. I will talk about this until someone asks another question.
Okay. Do you want to actually tell us, because you do a lot of this with your podcast?
Yeah.
And you do a lot of this with ABMP?
Correct.
So,
right.
Do you want to explain a little bit how that works?
I would love to do that. Oh, look at that. Thank you for putting up that banner.
Thank you, Lloyd.
Yes, Lloyd. So through ABMP, the Associated Bodywork and Movement Professionals, I do a podcast once a week, comes out on our Friday mornings. It's called I Have a Client Who. And what happens is people send me questions about odd things that have come up, usually in sessions, or sometimes it's not, but usually it's, in the middle of the session, I noticed this rash, or in the middle of the session, she began to tell me about X, Y, or Z, or I have a client who had Tourette's syndrome or whatever. And they send me a little note to my website or through Facebook, and I get their permission to share it. I don't share any names or any identifying information. But then I sort of take on the topic, I unpack it a little bit, and I talk about some possible choices for massage therapy, again, in that context of risks and benefits. And the whole thing takes about 10 minutes, and it's really fun. But it's so important that these questions be based on real life situations. So I would love to have I have a client whose stories from you, Paula, or any of your listeners. That would be just really super. Just send them to me at my website at ruthwerner.com. And do subscribe to the podcast. It's a lot of fun. And so I'm hoping that we'll get some questions tonight that I can then say, ooh, can I use this in my podcast?
Well, we had that one that might be a little bit easier because it was the one that was the latest one was with regards to, I call it Dupuytren, but you call it how do you pronounce
Dupuytren? Or if we're going to go French, it's going to be good. It's going to be Dupuytren.
Okay, Dupuytren. And like, how do you look at that treatment? Because I've seen lots and lots of therapists who try to work through the tendons, and surgeons love to chop that, give me a knife and cut the hell out of it. Yeah. But we know that that's not the biggest, that's not where we want to be spending our entire treatment focused time, because the body is a body.
Yeah, the body is a whole thing. And all right, so let's talk a little bit about that. And it's great because I actually did, and I have a client who about 2 weeks ago. So,
Oh, wow.
so I happen to be up to speed on this condition, which is also called palmar fibromatosis. So that's a little easier than Dupuytren.
Yeah, that's easier.
So this is a connective tissue issue, wherefore it is an idiopathic disease. We don't know why it happens. There is certainly a genetic predisposition, and there is an organization trying to gather data from anybody who has the genetic profile, just to sort of try and get better at treating it, because we don't have great treatment options for it. But what happens with this contracture is people develop, the most typical version is a middle-aged man. It happens in women too, but usually it's men, will develop a nodule at the base of their ring or little fingers, or both. And then the palmar fascia gets thicker and denser, and it pulls it's not the tendons, it's the tenosynovial sheaths of the fingers down. And so you end up like this. And so if you are familiar with the actor Bill Nighy,
yes,
he has it.
Yeah, Love Actually.
Yeah, exactly. And Emma, and all the others. If you watch him, you'll see he never opens his hands. He can't do it. And he has, what looks like it can get worse than that, because it can involve more and more of the hand. But to have that level of restriction is pretty severe. So we don't know what triggers the thickening of the fascia. The early treatments for it are really, it's a little bit of like, throw anything at it and let's see what happens. That people are put in a splint. People are taught to to stretch and exercise. People are taught stretching exercises for their hands, and especially to work with the muscles of extension in order to try and keep that range of motion good. But ultimately, and for some people, they'll have some degree of progression, and then it will stop, and that's it. It'll plateau, and it's all done, and it's not going to go any further, and so big deal. But for other people, it gets worse and worse. It can start in one hand, it can move to the other hand, and there are other places in the body this can happen as well. So I think there's a version of this that happens in other places, and I'd have to look up. I think it's the feet, but there's something else as well. And the conventional treatment for it, if the non-invasive things don't work, is we start with injections, collagenase injections to melt collagen. It's an enzyme to dissolve the collagen. If that doesn't work, then we're talking about slicing open the palm and releasing, that is to say, snipping the restrictive tissue, which is then, now we've got a ton of scar tissue. And so if people aren't really diligent about their physical therapy, it comes back. And sometimes it comes back anyway. So before we got started today, you were talking about, a strategy that might bypass the connective tissue aspect of this, and sort of, or the strongly localized connective tissue aspect of this, and look at the body more globally. Certainly couldn't hurt. The only thing it's going to do is maybe help. But truthfully, I don't think massage has a lot to offer for people with Dupuytren's, because if you're frictioning enough to break up that connective tissue, you're going to be leaving lesions. You're going to be causing bleeding. It's not the kind of, it's not what they taught us in massage school in the 1980s. It's not that.
No, you can't. It's physically, you cannot work at the pressure to break up tissue without creating so much damage, tissue damage.
Yeah. And so, my advice for, if you have a client who has Dupuytren's and they are pre-surgery and they want to keep as mobile as possible, do whatever feels good to them. Don't, use their pain tolerance as your limit. Teach them how to do things for themselves, maybe some pin and stretch for their fingers and things, right?
Nice.
So they can do it on their own. But in terms of having some kind of impact on the connective tissue, I think that that's wishful thinking. And if you are breaking up connective tissue, you're doing a lot of damage.
I like that. You're using radiotherapy
I'm
on the
looking at
hand.
that. They've started using radiotherapy on the hand. Haven't seen anything about results. That is curious. I haven't seen that. I'm thinking about, I wonder if this is radiation like is used for cancer patients, because I know that the effect on the tissues goes, deeper than the surface. And maybe that can soften it in such a way. It'd be like almost like inducing burns, but then whether stretching it out in the meantime. This is completely new to me.
Yeah, yes, okay. It is. Oh, that's interesting.
Yeah,
that is interesting. I mean, I suppose if you're injecting it with collagen fiber, like stimulating.
Collagen melter. It's a collagen melter.
Okay. Wow, that's so interesting. Yeah, my head goes, what's happening at the, I've got to go to you, someone this side. What's happening at the neck? What's happening to the brachial plexus? What's happening to the shoulder? What's happening to the humerus? What's happening to the elbow? And what is changing in our body alignment that's causing something at that very distal area to have to be working, building up?
Yeah, but it's, it again runs in families. It's very mysterious. For some people it's progressive, for other people it's not. Yeah. I'm interested in taking that in the opposite direction, which is, let's look at someone like Bill Nye, or the person who was being described in my podcast, who had it in one little finger and was beginning to have it on the other. So her massage therapist wanted to know if maybe they could slow it down. Right.
Yeah. Yeah.
So, even though a little finger is not a huge part of your body, it changes how you move toward things. It changes how you pick things up. It's going to cause compensation patterns elsewhere.
Yeah. Up the line.
So anything, So anything we can do to mitigate that, could be really helpful.
Yeah. Yeah. And that brings us back down to someone in the day spa industry. Mm-hmm. As long as they've got some level of understanding, they know that they can still provide a really good massage and calm down the nervous system, make the person feel more centered and pleasant.
Which the data suggests is really the main thing we do anyway.
Yeah.
And my background is in orthopedic work and working with musculoskeletal injuries. When I was in practice, I worked in a chiropractic clinic, and most of my clients were people recovering from motor vehicle accidents. Yeah. And here I am thinking I'm breaking down scar tissue, but really what I'm doing is giving people a break.
Yeah.
And we got good results. So something good was happening. It's just the story that I was telling myself about that was probably not accurate.
Yeah, and it's such a hard thing to change our mindsets around the story that we like to tell ourselves, because it's easier to just say it works than challenging ourselves to ask, why does it work? And maybe it doesn't in the way that we thought.
In the way you thought, right. And, the more we learn about those mechanisms, the more accurate we are in our understanding, then we can start doing that on purpose instead of by accident. So I'm a big proponent of working on purpose instead of by accident. I think it generally gets us to our destination a little better, a little quicker.
I think so, a little faster. That's exactly right. I'm going to ask, I have a patient who has had Parkinson's. She's a lovely person, beautiful person. She had deep brain stim done because of her tremor.
So does she have an implant?
Yeah. So I have to be very mindful of how and where I work on her, because you can feel the wire coming down through that portion of her neck. Actually, it is this side. And obviously wary to stay off that. But she's got terrible kinesthesia. So like she's falling everywhere. Like she's just, now it's actually, I asked her, would have you preferred the tremor to, would have you had the deep brain stim, had you had the choice? And she said, now I know. I wouldn't have, because this is far worse. Even though her voice is better, she can speak without all of the other side effects of Parkinson's, the swallowing reflex issues.
Right.
But she's in a terrible state. How have you got experience with people that have had the DBS or deep brain stim, and how we would treat them as therapists?
I don't have personal experience with it. It would be something I would love to look into. And so I would love to invite you, Paula, to just write me a couple of sentences about what you just said. And may I have your permission, please, to use it on I Have a Client Who, because I have been begging people to send me a story about Parkinson's, which is one of my favorite things to talk about.
Yeah.
So
she's
that, yeah,
great. She turns. If she turns on the spot, that's when she goes down. She's fine walking forward and back. But
so she's got a little bit of the Simone Biles thing going on, right? When she turns, she gets the twisties. She loses her sense of proprioception.
Yeah, maybe. Yeah. Yeah.
So is it her experience then that this just happened since the device was put in her brain, or was it okay? All right. So that's a complication of the device. And that would be the way you'd want to look at it, right? Complications related to DBS. That's where I will start to look up information about it. But and because it's related to this device, we might be limited in what massage can do for her, but the brain is remarkably adaptable, and proprioceptors lie all the time, and we can, they lie about how tight we need to be. They lie about where, they can tell you your head is straight and your head's over like this.
That's so true.
So we can, to a certain extent, proprioceptors are our favorite part of the nervous system, right? Because we can have some nice interaction with them. If you can figure out a way to work with her, so when she's laying on the table, if you turn her head, does she get dizzy? Do you know?
No, well, I haven't checked, but
that would be an interesting thing to check.
She doesn't normally mention the vestibular. She doesn't normally complain about vestibular in the brain stuff. She just goes, if I turn too quickly, that's when I just topple. So,
all right. So maybe it's vestibular, maybe it's something else. In any case, there is also some nice data on massage and falling risk.
Oh, okay. That's cool.
And so that would be something that I will look into when I prep that podcast. But and some of that is really super simple, like working on people's feet and then doing a timed up and go test, right? For how hard it is for people to get up from a chair to walk across the room. But some of that research also involves balance boards and some other things. So there's some nice information about massage therapy for elders and falling risk. It's hard to demonstrate massage reduces the risk of falling, right? Because you would need thousands of participants over years of time to compare the number of falls among this group versus among that group. But when people report, I feel so much steadier on my feet now, that's a nice outcome. So that's where I would start is looking at, there's some data on how to help people feel steadier on their feet. And I think that's a good place. That's a good place to start. It's it's lovely that she's giving you this opportunity to work with her. And you might consider, looking at some of this research and maybe choosing a measurement tool that you could copy, and then maybe tracking what happens, and then maybe writing a case report.
Funny you say that. I'm hearing that you are into research. I'm in the process of doing one for a woman, one of my lovely patients who had I saw her first when she had a foot injury. She fell and had a posterior dislocation and a humeral fracture.
Ow.
So I'm in halfway through my process of the case study for that, Ruth. So.
Oh, right on.
It's a bit tricky to oh God, I love
it's not easy, it's not simple, but it's so important, and truly it's within the skill set of every well-educated massage therapist. to do this. So when you have an opportunity, when you have a really special client that you think their challenge would help other people, case reports are a way we can share that widely and have it be well accepted by the general, by the rest of our cohorts, the rest of our community.
Yeah, and everyone listening out there, it is tricky, but it's worthwhile. It's so worthwhile doing, honestly. I'm stumped because my work with neurolymphatic stuff has got almost no research to it. Mm-hmm. So for me to find researchable material to move it forward is where I'm hitting that wall.
Well, so you might go back to sort of first principles and say, here's this person's situation. Here's what other people have done to help with this situation.
Yeah.
Here's how my technique sort of corresponds with those other interventions and why I think it could be useful.
Yeah. Yeah.
And that's all the introduction, and the introduction is not the whole case report. So the rest of it is really you doing your thing and telling your story.
Yeah. So interesting. So tell us about your journey with the Massage Research Foundation, because you were there for 10 years. Is that right?
Yeah. So
don't forget, people, if you want to ask questions, just pop them in the chat.
Yes, please go ahead and ask questions. The Massage Therapy Foundation is an international organization whose mission is to advance the science and practice of massage therapy through supporting research, education, and community service. And it has become a primary mission of the Massage Therapy Foundation to help massage therapists become more research literate. So they've put a big emphasis on, it's not their only emphasis, but they put a big emphasis on educational projects to, for instance, for you, if you went to the massagetherapyfoundation.org, there's so many resources on how to write great case reports, right? I mean, they will literally hold your hand through every step. They do a case report contest for students. They produce a podcast called Research Perch, where they will take apart research papers and talk about what makes them strong, what makes them weak, how this might be applied to practice.
Yeah.
And they also act as, it's a small scale funder of research projects because it's a small foundation. But they are very well connected in the research field, primarily in the US, but also in Europe and Australia and New Zealand, so that people who are working on projects that would benefit from being connected with others, the foundation is often a sort of the center of the web for helping people make those kinds of connections. So I came onto the foundation to work on the education committee. I was served as president for 4 years, which is the typical presidential term. And I have cycled off to make room for more people because we have wonderful, wonderful people serving on the board there. And so now I support them from afar, but it's no longer my foundation. I took it very personally for a long time.
Well, it's hard not to be invested. I know the feeling. On our board.
Sorry. Did you hear that? That's my dog.
Yes, I've got a dog.
He is a Shepherd Rottweiler mix, so he's a big man.
Wow, he sounds like a big man. We love dogs. I'm in a block of units here, and there's a lot of people with dogs here, and they're always talking.
Yeah, they have things to say.
They have lots of things to say. I'm trying to think. I've lost her first name. Thompson.
Diana.
Diana. Is she still involved?
Oh yeah. Well, not with the foundation particularly, but we're in touch a lot. She lives about 6 hours from me, which here is, quite close. And so, she has been putting a lot of her focus and effort into her electronic health records app called Hands Heal EHR. And,
you got that, Lloyd? I should put that in because Diana is another person like you. There's women out there that are like pioneers in my mind, have been really, really worthwhile. I can hear an echo from me. Anyway, she's well worth investigating further people if you want to get an understanding of, again, more education, more research, more ways to access research tips.
Mhm.
So both you and Diane are amazing. So
Yeah,
is
she's great.
is it Joanne Price? Is she also
Cynthia Price?
Cynthia?
Mhm.
Cynthia. Is she
Yeah, so
involved
I
in
actually
another one?
interviewed her for my podcast a few weeks ago. So so Cynthia Price is a PhD. She's a researcher of a particular approach to body work having to do with improving people's ability to pay attention to and express their internal feelings. So partly it's about, I feel really anxious right now, and that's why my stomach is upset. But partly it's about, I didn't realize that my neck was so tight, and maybe that's why I'm having headaches. So her focus is around this concept of interoception and sort of improved physical awareness, physical and emotional awareness. And she does this with special focus. And her research is really about using this approach to body work, which is not just for massage therapists, it's for other kinds of therapists as well, with people who are in recovery from substance use disorders.
Okay.
And so she had a wonderful I have a client who story about a young woman who had been addicted to heroin. She'd been living rough for 10 years, most of her life. She'd been living out, who got into this detox program and her learning how to feel her feet. You know, she says, Cynthia, Dr. Price said her feet were just like these blocks and she had no connection with them at all. And so that's something we really paid attention to. And now she's working on her feet every day and she's noticing a lot of other things. And, you know, it's a wonderful story. So yeah, Dr. Price is definitely very, very involved in her research and her, was it mindfulness? Oh gosh. MABT, but I don't remember what it stands for. I'm sorry.
Yeah. No, that's fine. And I'm just trying to hopefully get people that are listening to this now or who will be listening to this in the future an understanding of where do I go from here if I'm thinking, oh gosh, I do have some really interesting people I'd like to probably follow up on, and maybe by writing a document or a case study or a case report will be enough to, my one little piece could help in a bigger picture. So that the Research Hub absolutely has helped me immensely with the Massage Foundation. So that's a great place to start. I've avarice listened to every single webinar that you have been running in it and the groups that you've had through there. So they're all great portals to use. When a massage therapist is working in their clinic, how often do you think that they should be checking in with their patients and clients with regards to how they're feeling, that might be suggesting visceral or, you know, a pathology based versus just a soft tissue based during the treatment? Do you check in on them often, or you might be treating someone and go, oh, hang on, I'm going to stop for a minute and ask a question because this doesn't feel right? Got it.
Okay. Yeah. You know, the first answer to your question is always, it depends. So then you have to figure out what it depends on.
Yeah.
So let's say you're in the middle of a session and something comes up, you sense a change in the texture of the tissue that you haven't noticed before. Or your client told you on their intake form they'd never had a surgery and you are seeing what is obviously a surgical scar. Yeah. Or, you know, something unexpected that is related to pathology and communication, right? Comes up. And there are, I teach a class on this. It's called The Ethics of Client Communication, talking to clients about their health. And and everybody has these things that have happened, right? When you're in the middle of a session and something has come up that was unexpected, that makes you have to decide if you're going to interrupt the session in order to, you know, if that's necessary in order to be safe for the client, or, you know, occasionally to be safe on our own behalf. And I'm talking about pathology things rather than like sexual impropriety things.
Yeah. Okay.
There are other kinds of boundary violations. That's a different ethical quandary. But I'm, my focus is on the pathology aspect of at what point do we need, and what's the best way to interrupt a session. And there are lots of answers for that. And what it depends on is how much at risk do you feel you are for causing damage. So, a really common thing that happens, and here's a story I hear all the time. I got through the intake, nothing new on her form. She's on the table, blah, blah, blah. We're halfway through the massage. I pick up to work on her arm, and there's this big, drippy, blistery rash all over her arm. Well, she didn't say anything. So I say, tell me about this rash. And she says, oh, yeah, that rash. I forgot about that. What do you think that is? Right? So, and this is, I perhaps exaggerated with the drippiness. I teach pathologies, so that's my thing. So oozing is my bread and butter. But that kind of interaction happens with some frequency when you notice something where you might put yourself at risk, because who knows if this is contagious. Or put her at risk, like who knows if you're going to spread it, or maybe if there's any open lesions, then there's an infection risk and so on. In order to step forward, you need more information. And there's a number of ways to get that information, right, Paula? We can say something like, ew, what is that? Which is the first thought that might occur in your head. But it's usually better if they don't make it all the way out your mouth. What is that is not conducive to the kind of information that we really want. But saying, I am noticing, I just say get descriptive, but not alarmist. So I notice a raised red area on your arm that I haven't seen before. What can you tell me about this? And that's descriptive, but it's not scary.
Raised red area.
And it's not judgmental. And it's not, we have to be that language, especially because our clients are often in a halfway trance state, aren't they? And so we have to be careful how we bring this up. But if it's a matter of safety, then we have to bring it up. It was interesting because I have a client whose story that I haven't done a podcast on yet, and it was about skin picking disorder. Right?
Oh, okay.
Excoriation disorder, or it's not trichotillomania, dermatillomania. And people will nervously, the hair pulling disorder is, you can make sense of that, right? It's you get nervous, you pull a hair, it makes you feel better. The same thing can happen for people, and they pick at their skin, and then they can get the risk of, open lesions and infection and whatnot. And I started doing a little prep work to get ready to talk about that, because in a massage setting, that's a thing. Right. That can happen. Yes, Hans, I agree. Awareness is such an important thing to share, but we want to do that with some care. So one of the places I went on to pursue this skin picking thing was it was like a chat room for people who live with this disorder. I just Googled excoriation disorder and massage just to see what there was. And there was a chat room where people who live with this disorder talked about getting a massage. And how scary it was, because it made them feel very ashamed that their skin was marked and scarred and whatever. And one person said, I went in, I know I have all these weird dark marks all over my skin. She never said a word. It was such a relief.
Wow.
And now I'll go back. And, that is okay when there's no open lesions, right? And there's no risk for infection or whatever. We don't, in that moment while they're on the table, you don't need any more information. The skin is closed up. Maybe they had a rash or whatever. Yes, Hans, I'll speak to that in a moment. But, people who are maybe taking my advice an extra step might quiz their clients on skin lesions that that's not a safety issue. If the skin is closed and there's no risk of infection, move along here. There's nothing to comment on. Everything's fine. Right. And it was kind of delightful to see people say, I had a wonderful positive experience with massage when they have a disorder that makes them feel so ashamed of their body. So
yeah, that is very interesting.
Yeah, Hans put up a comment. State law, we cannot diagnose, only assess and treat within our scope of practice and training, and that's true. I hope that's true everywhere.
We call it working hypothesis. We always say
you can have a working hypothesis. You're allowed to say, and among those communication things is making your scope of practice very clear. But what you are allowed to do is say, you're not sure what this rash is. I can't begin to guess what this rash is. It might be contagious because you say it's getting worse instead of better. So we're just not going to work on this arm today. For your safety and mine, we are moving on now, right?
Yeah.
Or we're going to work through this sheet, or we're going to, whatever mitigation seems safe and appropriate.
Yeah, I quite often will say, listen, I'm not sure if the oil, the carrier, is going to aggravate the area, so let's just avoid this limb. And a lot of times people won't even realise that they've got something back there because they don't see it often.
Right. And if it's not super itchy, or if they were hoping you wouldn't notice, or whatever. We get what information we can. I agree completely. We don't diagnose. And that's the thing that we need to be especially careful about is, well, that looks like poison ivy. It might be poison ivy. I don't even, you have poison ivy, don't you?
No.
Do you
no.
Oh, all right.
No, but we have other things. Look, we have so much stuff that will kill you in Australia. We don't need poison ivy as well.
Okay, good. So
snakes, spiders, sharks, we've got everything out here.
Do you have, actually, I want to come back to that because you said earlier something about Lyme disease. Do you have Lyme disease?
Yeah, we do. We get people with Lyme's. Not as common, but we do get people with Lyme. It's not common up there?
Well, Lyme is named for Lyme, Connecticut.
Lyme, Lyme.
Lyme.
Yeah.
Was first identified in Lyme, Connecticut, where they thought there was an outbreak among young children with what they thought was juvenile rheumatoid arthritis. And there was like a big spike in that population, and they called in some guy named some guy named Bergdorfer to figure out what it was. And he's the one who figured out the tick-borne bacterium, which is now called Borrelia burgdorferi.
After him.
After him.
Yeah.
But I thought that was just a North America thing.
No, but I can't tell you whether I've had 2 people that I've treated in my 20-something years that have had Lyme's. Both of them have been had lived down in Byron, northern New South Wales area, and I think one of them had been in America, maybe both, so they might have contracted. It's
possible, or possibly, you got some ticks.
Congratulations. I would say it's probably the tick. I would say probably we've brought the tick back. We have tick gates, but they don't always stop the ticks from crossing. And funnily enough,
dang it.
I know they didn't read that sign. We've got a handful of minutes left. I'm dying to ask, and I actually put a thing out to Anne Williams. I did a little shout out to Anne Williams, Eric Brown's partner, about post-COVID, and I haven't heard back because she's all over it with COVID and long COVID, and she hasn't. I haven't heard back from her because I'm sure she's read that and gone, or she either hasn't seen it in Messenger or she's gone, oh my God, long COVID, I don't even know where to start. But do we have any research, any links people can look up?
I'm working on it. So I will be writing the best thing I can to approach a relatively comprehensive massage therapist's introduction to long COVID. Probably a little later in the fall.
I can see us having a large portion of I can see massage being very beneficial.
Huge, because there's so much, what we know so far is that the people who appear to have this have lots and lots of symptoms of, do you call it chronic fatigue syndrome or myalgic encephalomyelopathy?
ME or
CFS. And CFS is, at least for some people, a post-viral syndrome. And a lot of the things that we're seeing with some people with long COVID and some people with CFS with chronic fatigue, you know, have big overlap. And there aren't very many things the medical community can do for those folks, but they love them some massage.
Yeah.
But one of the reasons I've been delaying writing much about long COVID, I was getting closer and closer, and then Delta hit, and that was, you know, and now all our hair is on fire about acute cases, and we're, you know, the chronic, the long-term cases are getting less attention. But one of the real challenges about trying to even say complete sentences about long COVID is there's no agreement about what it is. There's not a diagnostic criterion. There's not any consistent guesstimate at what percentage of people who had COVID develop long COVID. We know that it appears to develop in people who had both mild infections and severe infections, but the people with the really severe, hospitalized, maybe on a ventilator for a while, those kinds of infections are, not surprisingly, at much higher risk for permanent organ damage, lung damage, heart damage, liver damage. But we have seen heart damage in people who had really, really mild cases as well. And, you know, so until we have some kind of agreement on what it is, it's going to be hard to say much about it. I have begun reading some of the theories about contributors to it, because there's the post-viral syndrome camp, and there's the, oh, we're still harboring colonies of virus camp, and there's the, we have stimulated an autoimmune reaction camp, and there's, you know, it's low grade central nervous system inflammation. It's, you know, there are, and it's probably a combination of those things, but I counted about 10 different, quite complex theories about what's going into long COVID. And so when I get ready to write something for massage therapists, let's just say I'm not really looking forward to it that much. But, you know, I mean, the people are hungry to be able to be helpful. And once we get over the hair on fire Delta thing, you know, and people are re-gearing to think about getting back to work and being able to work with more people, you know, if massage therapists just want to help. They really, really do. And the way we can work with breath work and anxiety, and both of those things are exacerbated by this infection. I just think our work, even just a matter of helping people breathe more easily, is going to be so impactful.
Yeah, and that comes back to Cynthia Price's comments about that awareness. Yeah.
So I developed a class for the Massage Therapy Association of Manitoba. I've been doing a lot of webinars this year. So so I did it for Manitoba in Canada, but it ended up being a really popular class, and I've done it in several, you know, I've done it several times since then, called ABC, Anxiety, Breath, and COVID, What Massage Therapists Need to Know. And I quote some of Dr. Price's work in the research about touch and awareness and breaking the panic cycle. Right. Because the panic and anxiety becomes self-fulfilling. When you can't breathe, you can't breathe.
Yeah.
Right. Yeah. And so if there's a way we can intervene and help people get reacquainted with what it means to take, sometimes we can't take a deep breath because that happens, but to take at least a calm breath to get on top of that can be really, really life-changing.
Yeah. To actually own the start of inspiration, and own the hold, and own the expiration, and own the hold. So when you can be mindful, and a lot of my work that I do is starting with breath work, because we want to get into parasympathetic nervous system states. So it's all about reducing the cortisol and upping the oxytocin and dopamine and stuff like that. And
that's absolutely the way in, for sure.
Yeah. And you can do that with patients like this. You don't actually have to have them on a table. If you can't get to them because Delta's stopping you, you can still get in and talk people out off the ledge as a therapist.
Yeah, absolutely. So I think there's a lot of promise for massage therapy in the context of long COVID. I just, you know, before I start to create something, I'd like for it to be accurate for more than a week at a time. So
Yeah.
I'm waiting for some of the dust to settle on it just a little bit. So
Yeah. Well, I'll be waiting to hear anything that I see from you, because I'll be throwing it into I've got 3 Facebook groups and my Instagram, so anywhere that as soon as we can find out anything, I'll be posting so that other therapists out there can get accurate information and ways to help. As you said, we love to help. We love to help.
Yeah. And I think there's a lot of promise. I think there's a lot more promise for massage therapy to be helpful for clients with long COVID than for clients with Dupuytren's contracture. So
yes. Yeah. In fact, Hans was the one who asked that question with it, because it's and I'm glad he's popped in to have a bit of a listen today. So hopefully that's helped a little bit with that, Hans, in that the actual pathology of it. Yeah, exactly. So guys, we're almost to the hour, and I'm going to let Ruth go home and pull back the screens and pat the dog and maybe have a supper or
it's time for a glass of wine at my house. So
good. Well, I'm slowly sipping on my coffee that it takes me all day to drink. But thank you so much for coming. I'm so grateful that you could spend an hour of time with us.
Happy to do it.
Anywhere on your groups and send it around. And if anyone's got questions after, which they always do, if you still want to pop them in the chat box underneath this, if there's any burning questions, I could tag you, Ruth.
Yeah. You send them on to me or Paula. Yeah, you just tag me. But in particular, if you have questions that I can answer that are related to your client interactions, this is just great fodder for the podcast, which, goes out everywhere and can, so that your curiosity can end up being helpful to many, many people.
Yeah, that's perfect. And I've been grabbing yours and throwing them into grabbing the snaps and putting them into my pages to help people.
Great.
Oh, I've got a little message from Loy. Okay, enjoy the wine. I don't know if it's red, white, or a rosé, but enjoy it.
White today. It's a little warm, so.
Okay, we'll have fun. Everybody, thank you so much for listening in. I hope you have a beautiful rest of the week and the weekend, which is coming up. It's gorgeous here in Brisbane over down here in Australia. Thank you again, Ruth.
Thank you, Paula. All right, take care, everybody.
Cheers. Bye.
Bye.